Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
Excellent. It's a crisp Sunday morning here in St. Louis. It's sunny at least. I'll have to give it that, but it is kind of chilly.
It is sunny. It is. I am seasonally affected. There is no doubt. And sunshine, even if it's cold, does wonders. And it's 2026.
It is indeed. How was your holiday season and Happy New Year?
Happy New Year. Holiday season was good. It was relatively quiet. We did make a trip to New York City, which was really fun. It's great being in the city over Christmas and the tree and the craziness. We had a good time.
Good. Was it cold up there? Because it was quite warm here in St. Louis for at least for Christmas Day.
Yeah, unfortunately, we left on Christmas Day, and the first day in New York was fine, and then it got really cold and it snowed a few inches, which again was fun-ish. But yeah, I don't love the cold.
But there's something very festive about New York City and snow in Central Park. I mean, I love that. As long as you're not having to get through the ice and everything that follows.
Yeah, no, that's exactly right. It's right. But there's nothing like New York City at Christmas time. It was really it's something.
Catch a Knicks game?
There was no basketball in the
What?
city. There was, I mean, it was so close because we came back on Sunday and I had a busy clinic on Monday. The Warriors did play in Brooklyn on Monday night, but I couldn't do it. Couldn't do
Should have planned ahead.
it. Yeah.
So, we got a fun episode lined up. We're going to go through some questions from a loyal listener, Andy Nelson, and we'll also go through a Thumb UCL series of cases that I've had recently, which I thought would intrigue you. But first, I guess we should thank our sponsor at Practice Link.
Absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Searching for words. Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com slash the upper hand.
Yes. So,
So we had the last episode that we dropped was a collaboration with the Resident Review podcast from our plastic surgery colleagues at Duke University, and was well received. And we got a list of questions here from our colleague and loyal listener Andy Nelson, who is a major contributor to the Hand Society's listserv, which I know a lot of people contribute to. So I wanted to propose a few questions to you, Chuck. I guess, how do you feel about endoscopic cubital tunnel surgery? Because I guess that Andy used to do this about 15 years ago. Fun and cool, but had a moderate failure rate, so he has stopped that. Do you have any role for that in your practice, or did you have any role for that in your training?
um, you know, it's interesting that you raised this question, and I back in the aughts, so early 2000s, I was doing a lot more cubital tunnel decompressions, and someone I really respect, Ty Cobb, was the person who was at that point the most vocal about the benefits of endoscopic cubital tunnel decompression. And Ty was in Iowa, as I recall at that time, and made a very logical argument for why it made sense. I couldn't get past the issue of, my incision is essentially just as small as your incisions, and I've been getting good results. I know exactly what I'm doing. My visualization is better, I would argue. So endoscopic does not make sense to me. Never made sense to me. And I think when I consider a decompression today, I'm very happy with a small incision. What's
What do you
what's your
think?
take?
Well, I guess I've never trained in it. I'm obviously heavily biased by our group's experience with endoscopic carpal tunnel from Dr. Gelberman's days. So, I never really thought about doing a cubital tunnel endoscopically and have unfortunately had patients referred to me who have had issues after an endoscopic cubital tunnel. So there's no role for me in my practice. And I agree the incision size for an in situ decompression is quite, reasonable. So what's your incision size and what do you think your conversion rate? I won't say failure rate because I think that's too harsh. What do you think your conversion rate or subsequent surgery rate is after an in situ decompression?
Yeah, and I'd like to flip that around and ask you as well. So I would say this, my incision is probably similar, maybe slightly larger than a mini open carpal tunnel. So it's probably 2.5 centimeters, so an inch. I make it slightly anterior to the medial epicondyle to limit the discomfort when people put their elbow on the table. And I'm able to easily sort of drag the skin posteriorly, dissect down to the nerve, and then with a couple of retractors, release proximally, release the superficial and deep fascia of the FCU without destabilizing the nerve. And so I carefully do not dissect circumferentially, just release what's on top. I don't excise the medial intermuscular septum, so I would call it a minimalist approach, which I assume is how you would strategize. But that's my incision, that's my approach, and my failure rate is low, but I'm super selective now about when I do this. In you were weed, and we reported failure rates of around 7%. Dr. Calfee then updated that more. I honestly think currently my failure rate is extraordinarily low because I almost never do the procedure. I would expect my failure rates 1 in 20, so 5%, but I only do a handful of these a year, probably 10 or less each year.
What's your current algorithm? Because we went through mine on the last episode, and I can summarize it again. But what's your current decision making for when you would offer an in situ decompression of the cubital tunnel?
Yeah, I don't offer it in adolescence, so it has to be, and I just think that the challenges are different in that population. So it has to be an adult with an absolutely stable nerve clinically, and obviously by ultrasound now. I think using ultrasound to confirm nerve stability makes all the sense in the world. I don't like it with a perching nerve, although recognize it can be done with a perching nerve. Um, and I and the literature doesn't necessarily support this, but I don't like it with more severe cubital tunnel. So earlier stage, motor and sensory intact, pain is perhaps pain and nerve symptoms that radiate distally are my primary complaints that I like to address through a decompression. And again, that's just not a population that I see. So remind us of yours.
Pretty similar. I feel like I've incepted your thoughts, and I've gotten into your head. Pretty similar. So I think the only other thing I would add to that is that, I think it has to be a patient that is comfortable with the possibility of a subsequent surgery. And it's more of a, I don't think the right term is decisional regret, but it's more of like saying, hey, like if we're looking at each other in 5 or 10 years and we're revising this surgery, are you okay with the fact that you had a smaller surgery with quicker recovery and you're having a second surgery down the line? Or do you want to be one and done and that's it? And I think that if it's the kind of patient it's like, hey, just be done, then we do a bigger surgery, which is a transposition. If it's the kind of patient that is comfortable with the fact that they're going to have a quicker recovery from this surgery, they might need something else done in the future, then yeah, do a decompression in the same settings, stable on ultrasound, no severe disease, not even moderate disease for me, and no advanced clinical findings in terms of motor or sensory. And then my conversion rate, I feel like I've probably revised one or two of my own, and that's about it. But again, like you, I'm pretty selective and don't do a ton of in situ decompressions. I think it's a great surgery for the right patient. But again, it doesn't come up that often for me. My incision's a bit bigger than yours for this, and this probably about 5 or 6 centimeters. And this is a case where I actually do go right on top of the nerve, so I'm more posterior. Usually for my transposition, my skin incision is anterior to the medial epicondyle for the same reasons you stated, and you taught me that. So this I think a an in situ decompression is a technically harder surgery than a transposition because this is where you have to be very precise, no wasted large spreads. You don't want to do anything to destabilize the nerve, and certainly not circumferential. And then, although listed as a common point of compression of the ulnar nerve, I don't think the medial septum needs to be removed in this case because the septum is only a point of compression once you've transposed the nerve because it's running parallel to the nerve. So I agree with you on that. So I guess we can leave that topic.
Well,
And
two
yes,
two final points, if I may. Number one, when it works, it is one of the best surgeries we do. It's just an instantaneous improvement in symptoms that really gives both the patient and the surgeon satisfaction. And number two, it is always best done when indicated with a carpal tunnel release. In other words, if you're doing both and you can get a quote unquote get away with a cubital tunnel decompression in addition to your carpal tunnel surgery, those are the happiest patients. And part of it is the carpal tunnel is such a reliable, good procedure. But when we combine them and you can sort of do both at the same time, that elevates the satisfaction quotient, at least in my experience.
absolutely. And how do you, I find it challenging to slow patients down enough after this surgery. because they're going to feel great and they're probably going to overdo it unless you tell them to pump the brakes.
Yeah, I don't think we can. It's like my total knee surgeon, total knee arthroplasty surgeon said, I can tell you what to do, but you're going to do what you're going to do anyways. And so we should share the same message, try to sleep with your elbows straight for a while. Don't do any major curls in the gym and anything that would put force on the nerve, but people are going to do what they're going to do.
I find it very similar to a common perineal nerve decompression. Patients, they're feeling really good most of the time, and they're going to try to do it. And I counsel them ahead of time because I had one patient who, after perineal nerve decompression, was feeling so good that he's like, "Yeah, I'm going to help my buddy move," and was going up and down the stairs and set himself back a few weeks in terms of recovery because his knee ballooned after that.
Yeah, that's the concern for sure. The swelling and a setback. Hopefully, if you're doing it on an absolutely stable nerve, you're not really worried about long-term problems. But ideally, you still. I tell people a month with a decompression before I want you back doing everything. Whereas with a transposition, at 6 weeks, I'll let you start doing more. But I really try to be protective for the first 6 weeks.
It's interesting. You're a little more protective than I am, but also I probably splint longer than most people and have them come in out of the splint for motion. And again, that's for transpositions. So let me squeeze in one more nerve-related question before we pivot to a more sportsy question or topic.
Shocking.
Why is the submuscular considered the sine qua non for final definitive surgery for ulnar nerve?
Well, for a couple of reasons in my book. Number one, it's sort of the last option in the sense that I don't know where better to put the nerve. Where else can the nerve run an essentially absolutely straight course without any kinks or turns, without any concern for dynamic shifting when you flex the flexor pronator mass or fire the flexor pronator mass? Um, where else is it more protected than beneath the muscles? Um, yeah, I think it's those factors. It's the nerve runs the straightest course, it's most protected, and ultimately it ends up being the last surgery for most. I mean, occasionally you hear about taking a submuscular and putting it back subcutaneous. That's when things get really bad. So that's how I think about it. How do you think about it?
Well, the reason I ask is that, Andy writes here, he hears almost anybody of substance and experience state that the ultimate revision is a submuscular, which he thinks is quite a big hit for patients, which it is. It's a bigger surgery and, you have a longer recovery. And I think we both counsel patients about that ahead of time. I think that, your points are absolutely right. It is the straightest course of the nerve. So it's not only, whether it's going to come anterior or not, but it's also the fact that it's not having to go up and down topographically like a hill. And if you transpose it subcutaneously, it still has to make that turn. I guess is that in the axial plane or it has to go from posterior to anterior and back posterior? And a submuscular puts it the most posterior or the most anterior and gives it the straightest shot. Um, what I've always wondered, and and Andy points out here, I mean, why doesn't the nerve scar to that bed where you put it after a submuscular transposition? So I guess that's really more capsule and MCL. Why doesn't it scar there?
Well, I don't think we understand when nerves scar. And so I'll throw a lot out there. Number one of my big populations, as you've heard me say before, is the ulnar nerve that has symptoms in association with UCL injuries. Those nerves are scarred inordinately preoperatively. Why does that happen? Second of all, why do some people scar with a subcutaneous and some don't? I mean, sometimes you go back and the scar is unbelievable. And the third thought is, some people will recommend a submuscular transposition and an elbow arthritis procedure, for example, at the same time. I hate that because you're allowing the joint fluid to bathe the nerve, and I find those patients often scar more because of that repeated trauma. I don't know why some scar and don't scar. Eventually, we're going to learn that. We're going to learn how to control that as well. I don't have. You must have hypotheses.
Honestly, I think it's motion. I think that as long as you get people moving early, the nerve is going to glide. Um, what I have not liked is when people have sent me patients who have had a subfascial transposition and that flexor pronator fascia is used and placed to the anterior subcutaneous skin. And if the patient doesn't move, for some reason, that fascia tends to scar pretty heavily to the nerve. And again, I'm biased with the people that I've seen and taken to revision. We don't know all these people that are doing what we think are doing well and what that nerve actually looks like. We've got a study in development right now looking at I think we have enough healthy and happy patients after transpositions that have had an ultrasound for research purposes for other studies that we can actually tap into that because all you see in the literature is the people who aren't doing well. I think it's important to understand a little better about what a patient who's doing well who has a transposition, what that looks like on imaging. So I'm curious about that.
Meaning, how much scar or where that nerve is sitting.
Yeah, where the nerve is sitting, there is any, I guess you can't tell scarring on an ultrasound, but looking at whether the nerve is enlarged still, because again, if you have a patient who's not doing well and you get an ultrasound as part of your workup, are you expecting that nerve to be enlarged, and does that help you, or the nerve's going to be enlarged in a patient who's happy anyway? So, I think there's probably some kind of gap in the literature that needs to be filled with that. But I guess I think it's they don't scar because we move them, and I think that's the biggest difference between now and when Learmonth first described that surgery about 40 years ago, is that people weren't moving their patients as early.
Yeah, I don't know that I 100% agree. I think we do move everyone, but some people still scar. And those are the ones who fail. I 1000% agree with the Eaton flap or the fascial flap. And some of our partners still use that fascial flap. I used it for, I don't know, 15, 20 years. Don't use it anymore. And I'm so much happier. And I think my success rate from using the subcutaneous fatty tissues to stabilize the nerve and pad the nerve, I am so much happier. But that fascial flap, whether it's just a small width flap like Eaton described, or a broader flap where the nerve is sort of placed under it, either way, I think that increases the chances of problematic scarring.
Yeah, so I guess we need to look a little more into this. There's more to understand. So before we move to our next topic, I'd like to thank our sponsor, Checkpoint Surgical, who would like to thank everyone who stopped by their booth at the AAHS, ASPN, ASRM joint meeting, and thank them for those who attended their lunch symposium, Controversies in Nerve Surgery.
If you missed the opportunity to order your copy of the new TMR manual at the meeting, you can get one today by visiting the resources section on checkpointsurgical.com. Do you have your copy, Dr. D?
I mean, I have all the copies, I guess. I actually don't have one. I need to go to checkpointsurgical.com and order one. So the I've had a couple of cases that I thought would intrigue you. So one was more of a chronic UCL patient or UCL injury in a patient who had an injury, I think at that point it was like 6 weeks back and just wasn't getting better and was kind of flustered by the fact that her thumb still hurt and was wondering what to do next. So, say you're picking up the ball 6 weeks after the injury. How do you think about that as opposed to if you're seeing them right away?
So, patient comes in, defined injury, pain at the medial aspect of the ulnar aspect of the thumb MP joint. Does she have instability, and what does that look like?
I think she has instability. On a dynamic fluoroscan assessment, I can see her phalanx translating when I stress the UCL. And on exam, she definitely has more laxity than the opposite side. I don't think there's an endpoint, but the MRI she comes in with is read as having an intact UCL.
And well, I mean that's interesting. Um, I'm gonna probably sink myself here and say things I shouldn't, but it is interesting to me the process of understanding MRIs, whether read internally or externally. I find myself agreeing less frequently with the official MRI readings than in the past. And the timing is interesting because we all know artificial intelligence is coming for radiology, and it's already starting to happen, and it's going to happen more. I will always, and I say that, try to find the official reading, especially of an MRI, but also radiographs, internal, external. I just think it's important to see it. It doesn't mean I have to agree with it. And in this situation, I generally trust myself more, but I want to incorporate the reading with my read. What did you think about the MRI It's
Well, I mean, obviously, I'm biased by the fact that I've examined the patient and I've done a fluoroscan assessment, and my hypothesis is that the UCL is incompetent. But I looked at the MRI and I thought there was some signal change. I thought that, it was at least a high grade sprain. But, you know, the official read said it was intact. So I made a point to put in my note that the official read says this, but I disagree. And then I tell the patient that I disagree with your official read.
Yeah, and you still have pain. I similarly had a recent patient, a high level athlete, who came into the office and was 4 months out from a UCL that was read as having a stenter. And I looked at it and I didn't see a stenter, which I thought was interesting because stenter is usually pretty classic on MRI. And I agreed that there was an injury to the UCL, but not that there was a stenter. And that matters as we think about what to do. So, yeah, in this situation, I trust my exam. And, just to be clear for younger listeners, one, it is always comparing the injured and uninjured side to understand native stability slash instability. Number two, it's a combination of things. For me, it is testing the thumb in extension and stressing and looking for an endpoint and also looking for degree of angulation. Two is stressing in slight MP flexion, 30 degrees is the described number, with the same stress test and assessment of stability. And three is whether there's any volar subluxation of the joint, which is different than the opposite side. So I was trying to put all three of those together with just the subjective positive or negative endpoint. Do you use all three of those?
I do. And then for the listeners, why do you stress in both extension and in 30 degrees of flexion?
Theoretically, we're testing the true collateral and the accessory collateral. So the accessory collateral is a more dorsal to volar from the origin on the center of the metacarpal head to the volar plate, which should tension more in extension, and the true collateral is more oblique and should tension more in flexion. I hope I got that right.
Yeah. I'm not questioning you on that. No, for sure. But I think the volar subluxation thing is important. And I assess that on fluoroscan imaging. And then I make sure to look at that intraoperatively as well. So we had a conversation and I said, look, I think that, she's frustrated. So she's looking at some kind of intervention. I think that I can help her. We proceed to the operating room and the ligament's intact, but it is stretched and quite patulous. What do you do in that situation?
Interesting. Can I go back for 1 second? I would say sorry, that's a really interesting case and a really good point. Do you ever numb the patient to get a better exam of stability? In other words, does pain ever limit you so that you feel like you need to numb the thumb with a local anesthetic to get a good exam? Because that is described. I've never personally found that helpful because it's just sort of one tweak usually, but have you ever used that technique?
No, maybe I'm not kind enough because it's just one thing, right?
It's one
And it's
thing.
the last thing, and it's the last thing you do, right? In your at least I do because I know that that's going to be painful.
Right, exactly right. Sorry. Sorry. So going back to your now you've approached the thumb UCL. I assume like me, you make a little gentle S-shaped incision along the medial joint. You've found your sensory nerve. You've taken it more dorsally. You've incised the adductor aponeurosis. Now you're looking at the ligament, and sometimes that's easy to see the ligament, and sometimes it's not, especially with scar. And it's interesting, we all assume because 95% of the time the injury will be distal on the base of the proximal phalanx. I would assess that first, and if it felt good, but the joint still felt unstable, and now you can stress as much as you want. My second step would be go back to the origin, and I would worry in this case about the origin. And then I guess theoretically a mid-substance tear could be possible. Something has to give more than a quote unquote stretch, I would think.
And again, I completely agree with you, but I was a bit humbled and surprised by this finding. But it was stretched. It was intact distally, intact proximally, and there was no mid-substance tear. And she still gapped pretty widely on fluoroscan assessment. So what do you do?
Um, well, I would treat the problem. And the problem is she had stability pre-injury. She doesn't have stability now. In this case, I would absolutely use a internal brace, and I would also tighten the ligament at the same time. And so when I do that with the suture and the ligament, bringing it more strongly back to the proximal phalanx, and add the support of the internal brace.
So not taking the ligament down, not pinning the joint.
So taking the ligament down is interesting. I would absolutely not be against that. So I would consider doing that. And I wouldn't be critical of someone who did that. The question becomes if it's truly an intrasubstance tear, you're going to have to really put a prolonged crack out and advance the ligament. So I'm not against that. I would, whether I took it down or not, I'm going to supplement it with suture. So yeah, I think you could take it down or leave it alone, but either way, I'm going to put a crack-out suture in the ligament to sort of advance it
Where would you
after the
take it
fact.
down? Would you take it down distally, mid-substance, or proximally?
I always take it down distally at the insertion of P1 because I just think that's what we're trained to do. That's where the injury always is. And if I would be confident though that it was intact at its origin, and I would trace the ligament along the way, which I know you did, but I would take it down distally. What did you do?
So, went through that same decision-making process and thought that I'm not going to burn any bridges by imbricating this ligament mid-substance. So I imbricated it and she tightened up. And I didn't want to pin the joint just because I didn't want to add trauma. It was stable on fluoroscan assessment, and we have a pre-imbrication and post-imbrication stress view, and there's no translation. I debated about the suture tape augmentation and decided against it.
So yeah, couple comments. Number one, I don't think pinning the joint is wrong. You've heard me say I don't do it anymore. I do it intra-op to when I use an internal brace to help just the mechanics of getting the stability I want without losing, flexion and all that kind of stuff. But there's nothing wrong with it for sure. Number two, if you don't pin the joint and you imbricate, I would go very slowly with her post-operatively to give her body a chance to heal this. And so for me, that would probably be casting for 4 to 5 weeks and then splinting probably for an additional 4 to 5 weeks. I would go slower with her for sure than I would go with someone treated potentially more aggressively with an internal brace.
Got it. And I guess for me, the pinning of the joint is, if I have multiplanar instability, meaning that I've got that volar subluxation, and to your point about just making it harder to hold things in place, so you can get your whether you're doing suture anchor alone versus augmentation. If you have multiplanar stability, I think that's helpful to pin the joint. But I've moved away from it because just don't want to traumatize the joint more than I have to.
Yeah, so just for clarity, the intra-op pinning that I do, and again, I pull the pin before we leave the OR, is such that I can get the reduction and repair in the position that I want. If you tighten a repair with the thumb MP joint fully extended, you will lose flexion. Now, clearly not the end of the world, but not ideal either. And so when I pin the joint, I over reduce it slightly, meaning the MP joint will be 0 to 5 degrees in ulnar deviation, and I flex it 30 degrees. And that's the position I try to do my repair in. Not over tightening an internal brace if I use one, but tightening it snugly. And then I pull my pin and I check my motion. And hopefully, you have full MP motion. The danger is that patient who's very mobile at the MP joint, 0 to 70 degrees. And if you take that away, they will not be happy. The flip side is that patient with high mobility at the MP joint is far less likely to injure their UCL. It's the patients that have a square metacarpal head that are just stiffer. To me, those are the patients that more likely injure their UCL because they just don't have that mobility.
Really, really good points. I have nothing to add, to be honest with you. I do have a second case that I'd like to present to you, if that is all right.
I love it. That was a great case. That's interesting. It'd be
Yeah,
interesting to see how she does.
absolutely. So this is more of a classic case, adolescent injury while doing a contact sport with a pretty visible and palpable stentor on clinical examination. So how do you just, this is again more of a textbook case. How do you proceed with the exposure? Is it any different? How do you handle your adductor aponeurosis? Knowing that the ligament is indeed ruptured pre-op.
Yes. So when we have a stentor, first of all, a good MRI of a patient with a stentor is an awesome MRI because you have the adductor aponeurosis, and proximal to it, you'll have this ball. And the ball is the ligament and is sort of curled up and it cannot heal. And that is why this is a absolute surgical indication.
Would you get an MRI if you knew this based on exam?
So
Other than having a cool MRI in your portfolio?
I have enough cool MRIs. No, if I knew by whatever clinical exam, ultrasound, whatever, I would not get the MRI. But if there's uncertainty, then an MRI is very nice. One of our partners, Marty Boyer, will say that he can always feel a stentor. I do not have that same level of confidence in my ability to feel a stentor, but sometimes you can. It is interesting, as you approach it, you still release the adductor, the aponeurosis, that little sheath, and then you will see the balled up tendon before you do that release, and then you do the release, and what you hope is that the you can unfurl the curled up ligament if only it were that easy. And that's the challenge with this case is that trying to get that ligament back out to length is not always easy and it's not always completely successful. So I'm curious as to what you found in this case.
Well, that's where the chronicity comes into play, right? So if this is a long time ago, then yes, I'm much more concerned. I'm checking for a palmaris. I'm thinking about other things that I could use potentially. But this was fortunately a forgiving case in terms of it wasn't that long after the injury. Was actually seen in our injury clinic, was referred to me pretty quickly. And it was nice. It was actually like, man, I told the fellow, I was like, you should take a picture of this. Like, this is like classic, it's a classic stentor. And, when I talk to patients about a stentor, I kind of talk about it like it's like somebody snaps a window shade and just rolls back up and it's stuck there and you got to unroll it. Marty's other point about UCL is that, you can't cause a stentor like on your exam. That's always a concern is why some people say the resident fellow walks out of the room and they're like, oh, I didn't stress the joint because I didn't want to cause a stentor. I'm like, you're not causing a stentor on your exam. And I agree with Marty on that.
Totally true. There's no force that we can apply like the injury force that was already applied. And so that is in the older textbooks that don't stress too hard or, don't, if there's a fracture, be careful not to stress, that's all BS because, we're not going to stress harder than it's already been stressed. And I think that's true in a lot of things we talk about. Whatever we do in clinic is never going to be like the initial injury was. Um, and so, this is a part of your practice, maybe a little less of your practice compared to my practice. How do you think about repair in this situation? Do you always do a suture anchor with a Krakow? What is your indication to add an internal brace? Do you ever add an internal brace? Because our practice of 7 hand surgeons all see this differently. And I'll just say, surprisingly, maybe I don't always use an internal brace. I will sometimes, but I don't routinely do it. At least one of our partners does it almost every time. How do you think about it?
I think I'm more likely to use one than not. But I think in this case in particular, knowing that this is a young person and, I may not trust them entirely and they're going to want to get back to sports pretty quickly because they're a high level. I've used the internal brace, suture tape augmentation. Arthrex, if you're listening, more than happy to have you sponsor us, just so you know. But yeah, I think it's helpful. It again depends entirely on activity level, but more cases than not.
Yeah, I think that's a very fair approach, very reasonable approach. Knock on wood, I've not seen one fail. I do worry, and this is well reported in the literature about osteolysis, but knock on wood has never been a practical problem for any of my patients, and I've been doing it for more than 10 years. I do agree. Arthrex and I do not have a relationship with Arthrex. I did spend time in their lab on Saturday
Not yet.
morning.
Not yet.
I did spend time in their lab on Saturday morning doing some dissections, looking at the TFCC, and it was very fun. It's you kind of get out of the hustle bustle of what we do and just kind of kick back and really get into it. It was fun. Those things are fun that we don't do a lot of.
Well, it kind of resets you and brings you the joy. We've got our plexus dissection lab coming up that we do every year, and I'm excited about that because again, it's like, oh, this is the anatomy that's really fun and cool.
Wait, tell me
Um,
more. Wait, what's your plexus dissection lab that you do every year that I've never been invited to? Thank you. Don't invite me this year.
yeah, this started. I think it was Amy Moore ran it when I was a fellow, and then she kind of asked me to help take it over, and then subsequently she left to go to Ohio State. But every year since 2015, at least when I started, we have a lab where we have a torso that has a head and neck attached, and while the fellows and residents are working on other extremity specimens, we're able to do a plexus dissection. I prosect one side. Maybe this year I'll ask David Wright to do it since he's our new partner. And on the other side, the fellows get to do their own exploration of the neck. So I think it's really helpful. Then obviously they can do nerve transfers around the shoulder, which when you have a disarticulated specimen, which we normally do, you don't get to do. And then intercostals, that kind of thing, which is you don't want your first time harvesting intercostals to be in a live patient, put it that way. So good opportunity for them. And, we enjoy it every year.
That's great. So this is orthopedic residents and fellows and plastics residents and fellows.
Correct. And you're
Very
more than welcome to join.
I don't want to get in the way. You guys have a good time and look at all those nerves, and it'll be super fun.
Yes. So yeah, the UCL case was gratifying. We're on schedule for with in terms of recovery and back to high level competitive sports. So wanted to throw you those couple of cases, throw you a bone there after all this nerve talk.
Yeah, I mean, the beauty of sports care is you treat the patient, and within a reasonable length of time, they're back doing their thing. Is that how it works with nerve surgery?
Totally. Totally. Well, I need the sports cases to balance out all of this waiting for nerve. I
That's
think
exactly
everyone
right.
always asks me if I want a purely nerve practice, and I'm like, I can't. I need the distal radius. I need the trigger fingers. I need the UCLs. I just need things that to reaffirm the fact that yes, we can make people better pretty quickly. And I think most people, if you're orthopedically trained, have gone into ortho for that reason, is that you like fixing things and getting people back to doing what they love to do.
Yeah, in less than a year. Yeah, yeah, exactly. Exactly. Love it. Love it.
All right. Well, you have a wonderful rest of your crisp Sunday. Hopefully, watch some good football and rest up.
Awesome. Good to see you. Thank you.